Uh, hello, hello everyone. Uh, I am Dr. Mohammed Hassan from Chuktai Institute of Pathology, Lahore, Pakistan, and I welcome you all to this online Zoom session for Histopathology outreach program, which is Hope for All. And I can see that our guest speaker, Dr. Rajendra Singh, he has already joined us. Thank you very much, Dr. Raj. It's a pleasure to have you.
Thank you very much. Thank you for the opportunity.
Yeah. Uh, Before the session, let me introduce Dr. Rajendra Singh. He is the co-founder of Pathcast, which is the online and the digital platform for sharing pathology images. And it is the largest library of digital slides. He's also director of dermatopathology and digital pathology at Summit Health at New Jersey, USA. And Dr. Raj, you can share your screen and start the online session. So,
Okay, thank you very much. Okay. So you can see my screen?
yes, we can
Okay.
see the screen. Yeah.
Okay, very good. So good morning, good afternoon, good evening, wherever in the world you are. My name is Raj Singh, and thank you, Dr. Mohammed Hassan, for the opportunity to present reaction patterns in dermatopathology. I know like dermpath is not like a very easy topic to handle, like in 1 hour, like trying to cover the entire inflammatory dermpath might not be easy, but we'll try our best basically. And feel free to put in any questions in the chat if you want to put any question in the chat, and we'll try to answer them as we move along. So in reaction, when we talk about like dermatopathology, like you can divide it into two branches. One is the inflammatory dermatopathology, and then the other one is the neoplastic dermatopathology. When you talk about inflammatory dermatopathology, like most institutions will train you to look at inflammatory dermatopathology in a very algorithmic approach. And what I mean by an algorithmic approach is like you should try to look at the slide in a very top-down matter, like start from the top and go to the bottom rather than trying to like put up a slide and say this is a diagnosis. So residents and fellows many times will jump onto a slide and say, oh, this is lichen planus, oh, this is psoriasis. Rather than trying to do that, it is better to like start thinking in a very algorithmic approach to see first what is the reaction pattern in the slide, and then within that reaction pattern try to come up with a differential diagnosis. So like you are almost like a Sherlock Holmes that is trying to like look at clues within the slide. So what is the reaction pattern? Within the reaction pattern, what is the sub pattern? And then from the sub pattern, you then try to come up with a differential diagnosis. But like, even Sherlock Holmes couldn't solve many of the cases alone. Many times he always wanted the help of Watson. Like Watson was the person that always gave him the clue that helped him clinch the diagnosis or clinch the case. So for a dermatopathology, like your main partner is always going to be your dermatologist or your clinician. So this is a slide from Whedon where he talks about a dermatopathologist and a dermatologist being almost like a husband and wife. So if both of them work together, then the house is always going to be in peace. If both of them are not working together, you know what will happen in the house. So if you really want to make a good diagnosis for the patient, you have to work very, very closely with your dermatologist or your clinician, almost as if you're working with your husband or wife. And that will help you definitely become a very good dermatopathologist and like give a better diagnosis. The other thing is like in dermatopathology, you always have to make sure that you think about the common things first. Like people tend to always try to think of the uncommon things, but it is better to think of common things first. And in the world of pathology, this is a slide from Dr. Rapini that equates common diagnosis to horses and uncommon diagnosis to zebras. But it is always like important to think about the horses and then keep the zebras in the back of your mind so that you think about them, but don't always jump to the zebras first. Think about the horses first and then talk about the zebras. Like what your mind doesn't know, the eyes will not see. This is something that I've always stressed upon. So you have to like first start looking at the slide carefully and see what you see on the slide rather than jumping to a diagnosis. For like this is an example for like what the mind doesn't know, the eyes will not see basically. Like if you look at this image, what do you see right now basically? So like many of you might just see a black and white blotches of images basically because your mind doesn't know what to see here. But if I tell your mind that this is the outline, if you look at this, it is a cow that you can see here basically. Now, like because I've shown you this and your mind knows that I'm looking at a cow, your eyes will now easily see it here. So now if you go back and look at this image again, you will easily see the cow now. But previously it was difficult to see the cow. So if your mind doesn't know, your eyes will not see it even if it is in front of you. So it is very important to like read a lot and understand dermatopathology, like the subject matter. And once you know, have the good control over the subject matter, then it will be much easier to see what you see in on the slide. And that is not only for dermatopathology, it is for the entire pathology. So like I said, your clinician is your most important partner in dermatopathology. So like if you have to form rules, what are rule number 1, rule number 2, rule number 3? It is always a clinico-pathological correlation when it comes to inflammatory dermatopathology. And the other thing that you also have to remember as a dermatopathologist, you always do not have to like pigeonhole every case into a diagnosis. Like even if you give them some kind of a reaction pattern, the dermatologists are good enough to like come to a final diagnosis. But you always don't have to give them that this is lichen planus or this is benign lichenoid keratosis. If you just give them a list of differential diagnoses, then based on the clinical input that the clinician has, they will be able to come to a definitive diagnosis. So it is not very important always to give a definitive diagnosis. If you can give a list of differential diagnoses, many times that is good enough for the dermatologist. And like I said, like try to take a pattern approach rather than like jumping to a diagnosis. So always like looking at an inflammatory derm path, try to start from the top. What do I see in the epidermis? What do I see at the dermal epidermal junction? What do I see in the dermis? And then what do I see in the subcutis? If you follow that pattern and you try to train yourself in that, your mind in that pattern, by the time you finish your residency or by the time you finish your training in pathology, you will have a very good algorithmic approach in your brain on making a diagnosis. So with that, now we will move on to the cases that I shared with you. Like that, with that background, we'll start moving to the cases that I shared with you. And again, these are following a reaction pattern. We are not trying to like jump to diagnosis. We are trying to follow a reaction pattern. So by the end of this lecture, if you can have that kind of a pattern recognition in your brain, like I think my work will be done basically. You don't have to like get to a definitive diagnosis all the time. Just try thinking of that algorithmic pattern to develop in your brain. So this is the first pattern that we see here. So if we zoom into the slide here, and like if you look at the top of the skin there, this is the stratum corneum. So we don't see too much changes in the stratum corneum. I don't see any parakeratosis. I don't see hyperkeratosis. I don't see any kind of neutrophilic abscesses or anything here basically. Then I come to the epidermis and definitely there's a lot of spongiosis in the epidermis. And like spongiosis means eczema. Like when you talk about eczema in the skin is collection of fluid. So spongiosis is very similar as collection of fluid within the epidermis. And because there is collection of fluid, you see that these keratinocytes of the epidermis has these keratinocytes in they start separating out and there are spaces in between the keratinocytes. So increase spaces within the keratinocytes and sometimes these spaces become so big that you start forming these vesicles. So this is called vesiculation, which is part of the spongiotic reaction pattern. So increased spaces between the keratinocytes and vesiculation is what you see in the epidermis. And also you will start seeing the lymphocytic exocytosis within the epidermis. So these are all lymphocytes. This blue dots that you see is the lymphocytes. And that is part and parcel of a spongiotic reaction pattern. So, and it is the term that you will read in the books is called lymphocytic exocytosis. So, exocytosis is the lymphocytes going into the epidermis in a inflammatory reaction pattern. So, increased spaces for the keratin between the keratinocytes, vesiculation, lymphocytic exocytosis. Then you look at the dermal epidermal junction, there is not too much of a change at the dermal epidermal junction. And then within the dermis, I see a superficial perivascular infiltrate. I see this perivascular infiltrate in the dermis. So if I go high power, it's composed mostly of lymphocytes, and then there are a couple of scattered eosinophils. You can see a couple of scattered eosinophils. So if you take all this together, then we are dealing with a spongiotic reaction pattern. And if you can give that to the clinician, they are more than happy, because remember, spongiosis can be caused by 800 different things. So trying to pigeonhole this into a very specific diagnosis just based on histology is going to be very, very difficult. So if you tell them that this is an acute spongiotic process, maybe it could be allergic contact dermatitis, it could be nummular eczema, it could be reaction, that is more than enough. They will then definitely decide what the correct diagnosis is. But all you need to tell them is this is an acute spongiotic process and differential diagnosis includes this, this, and this. And also, like for every spongiotic inflammatory dermatopathology, it is always better to do a PAS just to make sure there is no fungus associated with the inflammatory reaction pattern. So that was about the first reaction pattern. Now coming to the second reaction pattern, this is a very classic case of psoriasis. Like a clinician is never going to biopsy this and send it to you because they don't need a pathologist to tell them that this is psoriasis. But when do you get a biopsy of psoriasis is when the patient is not responding to the treatment. So when you get a biopsy of psoriasis, what we will discuss are the classic features of psoriasis. But remember, the patient is only going to get a biopsy when the patient has not responded to the treatment. And the clinician now wants to confirm whether the patient has psoriasis or not. So you might not see all the classic features that we talk about when we talk about psoriasis. So in the textbook, they will give you this very classic features that we will discuss right now. You can see, like if we talk about the classic features, you see a confluent parakeratosis in the stratum corneum. And by parakeratosis, what do we mean by parakeratosis? Is the retention of the nuclei within the stratum corneum. You can see all these blue lines here. This is all the nuclei within the stratum corneum, and that is what is termed as parakeratosis. So when a skin in the skin, when the skin is developing, or like as the skin evolves, the keratinocytes, they start from the basal layer, and as they mature, they go to the top, and like by the time they come to the top, then they get shed off basically. But if this process is happening very fast, like that process normally takes around 14 days. But if it happens very fast, then by the time the keratinocytes come to the top, they do not lose the nuclei. And that is the reason you see this nuclei within the stratum corneum. So if you look at things that have a increased proliferation like actinic keratosis or squamous cell carcinoma or psoriasis, in which the underlying physiology is increased proliferation of the epidermis, you start seeing this parakeratosis in the superficial part of the epidermis. And the underlying physiology is always increased proliferation of the epidermis. So you see this very confluent parakeratosis on the top. And then when you zoom into the parakeratosis, you will see this neutrophilic microabscesses within the stratum corneum. And that is a very important feature to look for in psoriasis. So this neutrophilic microabscesses that you see in the stratum corneum is one thing that you want to look for. And then if you look at the epidermis, it has this pattern that is known as psoriasiform hyperplasia. And what do we mean by psoriasiform hyperplasia? Is this thickened bulbous rete ridges. So these are the rete ridges that you could this bulbous projection of the epidermis is known as the rete ridges, and you can see they are very bulbous. So this bulbous proliferation of the rete ridges is what is termed as psoriasiform hyperplasia. So you see this way, psoriasiform hyperplasia of the epidermis. And then this part of the epidermis which you see over the dermal papillae. So this part of the dermis is the dermal papillae. The dermis going within the epidermis is the dermal papillae. And this part of the epidermis is termed as the suprapapillary. because dermal papilla, it is top above it, so suprapapillary. So the other thing that you will read in psoriasis is thinning of the suprapapillary plates. So this part of the epidermis that is above the dermal papilla is the suprapapillary plate, and the thinning of the suprapapillary plate is another feature that they will talk about in psoriasis. And then when you look at this dermal papilla, you also see increased capillaries here. Now, if I go back to the spongiosis case, sorry, if I go back to the spongiosis case here, or let's go and find another slide. If I go here, we'll come to this slide, but you can see like this is the stratum corneum, this is the epidermis, and the second layer in the epidermis is called the stratum granulosum. And this is called stratum granulosum because you can see like this layer has a lot of keratinocytes that have granules in them. So that is the reason this is known as stratum granulosum. So when you come back to the case of psoriasis, it tends to lose that stratum granulosum. So if you come here back and look at the high power here, you see the granular layer is, you don't see the granules here basically. So there is a loss of the granular layer in psoriasis. And then you have this superficial perivascular lymphocytic infiltrate. And if you go high power, it is mostly lymphocytes. So now if we go back and like summarize, you have a confluent parakeratosis on the top with neutrophilic microabscesses within the stratum corneum. You have loss of the granular layer in the superficial part of the epidermis. You have thinning of the suprapapillary plates. You have increased capillaries within the dermal papillae. And then you have the psoriasiform hyperplasia. And then you also have the superficial perivascular lymphocytic infiltrate. So if you see all these features, then your diagnosis is going to be psoriasiform dermatitis compatible with the clinical impression of psoriasis. So that is the classic psoriasiform case of psoriasis. But remember, I told you like many cases of psoriasis are not biopsied until the patient does not respond to treatment. So the patient has already been given treatment. So they will not always have all the features that we talk about in a classic case of psoriasis. So when you get a biopsy, you might not see confluent parakeratosis. You might see parakeratosis that is like partially seen, and then you might see hyperkeratosis. You might not see complete loss of the granular layer. You might see granular layer lost in some places and not lost in the other places. But the one constant feature that you always need to say this is compatible with psoriasis is the presence of the neutrophilic microabscesses. So you want to see that if you want to say this is compatible with psoriasis. So always this neutrophilic microabscesses have to be there. If you don't have the confluent parakeratosis, if you don't have the loss of the granular layer, if you don't even have the psoriasiform hyperplasia, but the clinician is saying rule out psoriasis, if you see the neutrophilic microabscesses, you can still say this could be compatible with psoriasis. Remember, because the patient has already been treated. And one more important thing is whenever you see neutrophils, you always have to do the PAS stain to make sure this is not fungus. Because like 1 in 100 cases could be related to fungus. And that one patient, you're going to save them from lifelong treatment of psoriasis. Psoriasis is a lifelong disease and they will be given treatment for life. For that one patient, if you don't do the PAS and you miss the fungal disease, they might just be given treatment for which they don't need basically. And psoriasis treatment can be pretty expensive. So it's better to always do the PS even for that 1 in 100 case that is going to be positive for a fungal disease. So other diagnoses that you can think of, like this is another case where this patient is a much younger patient, like the patient only has a history of 7 days. And they present with dew drop lesions and the clinician says rule out guttate psoriasis. So that's a common disease in younger patients where they have a streptococcal throat infection and within 7 days, they develop the skin lesion that look like guttate psoriasis to the clinician. So like because this is a very short history of 7 days, you don't have the psoriasiform hyperplasia, the loss of the granular layer, the confluent parakeratosis is not there. But remember what I said is you will always see the neutrophilic microabscesses. So if you go high power and you scan the epidermis very carefully, you are going to see the parakeratosis, and then you're going to see the associated neutrophilic microabscesses at least somewhere. So if you see those, you again do the PA stain. You can see like there are increased capillaries in the dermal papillae. It is starting to get a little bit of a psoriasiform hyperplasia, but doesn't have all the classic features. But given the presence of the neutrophilic microabscesses, after I've ruled out the fungal infection, I can still say this is compatible with the clinical impression of gutted psoriasis. And then the other differential diagnosis for psoriasis is always this disease and it is always a differential diagnosis for any inflammatory dermatopathology. So what do we see here? Here we see the psoriasiform hyperplasia, but it is not very regular like you saw in the classic psoriasis. This is known as irregular psoriasiform hyperplasia. But again, associated with that is a very dense infiltrate here in the dermis. So if I look at this, then if I go up high power and start looking at this very carefully, I can see that the infiltrate also shows some plasma cells here basically. So this is a very dense infiltrate in the dermis, predominantly lymphocytic, and then this associated plasma cell. So this one condition that you always have to keep in mind for any inflammatory dermatopathology, especially when it shows a combination of patterns. So here you have a little bit of a psoriasiform hyperplasia, and then this dense lichenoid infiltrate makes it like a lichenoid dermatitis. So you have a combination of two patterns, psoriasiform hyperplasia and lichenoid dermatitis. So when you see a combination of patterns, the one condition that you should always think of is secondary syphilis. And you always do your spirochete stain to make sure you are not missing out syphilis in these cases. And sometimes remember, like the spirochete stain is not very, very sensitive. You might miss it. So if you still think that this patient is going to be secondary syphilis, you always pick up your phone and ask the clinician to do an RPR, a serological test known as RPR, which could be positive despite a negative immunohistochemical stain for syphilis. So if you think about it, like I said, think of the zebras also always, but you don't have to always diagnose them. But in cases like this, think of secondary syphilis and make sure that you do the immunostain for spirochete. And if it is not positive, then you always pick up your phone and ask the clinician to do the RPR basically. Another condition that can show you this psoriasiform hyperplasia, here you can see like this is also shows the psoriasiform hyperplasia, but again it is not very regular like you saw in psoriasis. This is known as irregular psoriasiform hyperplasia, where you have this very bulbous rete ridges, but the other features are absent. You have a very thick granular layer, you have hyperkeratosis, you have focal parakeratosis. So this is a case of lichen simplex chronicus, where the patient is like scratching the skin quite a bit, and then the skin reacts in this way basically. So you have this very thickened stratum corneum. You have a very acanthotic epidermis. Acanthotic means very thick epidermis. And you have this bulbous rete ridges, and there is a little bit of a dermal fibrosis. So this is how the skin will react when the patient keeps scratching all day basically. If they are scratching all day, it could be related to a liver disease, it could be related to some other internal causes, but the patient is, it may be related to some drugs, and the patient is very itchy and they keep scratching, and they can develop this reaction pattern in the skin which looks a little bit psoriasiform but doesn't have the parakeratosis, doesn't have the neutrophilic microabscesses, doesn't have the loss of the granular layer, but has some of the other features. So this is again a psoriasiform reaction pattern, but the diagnosis is going to be lichen simplex chronicus, and sometimes this can present as almost like a nodule, and then the diagnosis is prurigo nodularis. And these are very common things that you see in the skin. Lichen simplex chronicus and prurigo nodule are very common things that you're going to see in the skin. Coming to the third reaction pattern. So this is again a very classic case. A clinician again is not going to biopsy this kind of a lesion because they know this is lichen planus. But in the skin, how does it look basically? So now when we again start looking at the top, there is not too much of parakeratosis here. There is a little bit of a hyperkeratosis. And then you see in the epidermis, there is almost like a very thickened granular layer here. And this is like almost like a wedge shape. So this is the granular layer, and this is termed as wedge shaped hypergranulosis. And then in the dermal epidermal junction, you see this very dense lichenoid infiltrate. The one thing that you have to be very careful about is this lichenoid infiltrate hugging the dermal epidermal junction, or the other word could be obscuring the dermal epidermal junction. So hugging and obscuring is very important to look for, because many times what happens, I've seen residents and fellows, when even there is a very dense superficial infiltrate, superficial perivascular. So the infiltrate is actually perivascular, but it is so dense that people feel that it is a lichenoid infiltrate. But that infiltrate will have some kind of a space between the epidermis and the dermis. It is not obscuring the dermal epidermal junction, or it is not hugging the dermal epidermal junction. So always differentiate between a very dense superficial perivascular infiltrate versus a lichenoid dermatitis. And what do we mean by lichenoid dermatitis is when you have this very dense lichenoid infiltrate that is hugging the dermal epidermal junction or obscuring the dermal epidermal junction. So if you see that, then you are in the lichenoid reaction pattern. So, and then because this lichenoid infiltrate is hugging the dermal epidermal junction, it destroys some of the keratinocytes. So if I look at these keratinocytes, some of them get destroyed and they undergo apoptosis. And when they undergo apoptosis, you start seeing these pink structures here, these apoptotic cells. You can see these pink structures here. These are apoptotic keratinocytes. Some books call them colloid body, some books call them apoptotic keratinocytes. And there are very different kinds of terminologies that you will see. But the main underlying pathophysiology is because the lymphocytic infiltrate is attacking the dermal epidermal junction, some of the keratinocytes at the base of the epidermis undergo apoptosis. And because they undergo apoptosis, you start seeing this dyskeratotic keratinocyte. Colloid bodies, dyskeratosis, many different terms people will use. But the underlying thing that you see is a very pink cytoplasm, and then the nucleus can be very pycnotic. So here you can see there is a very small nuclear edge here basically. And sometimes there is no nucleus. It depends at the level at which the cell was cut. Because it's a very small pycnotic nucleus, at some level you might see the nucleus, at some level you might not see the nucleus. So in some of these, you might only see the pink, very pink cytoplasm, and in other you might see the pink cytoplasm with this very pycnotic nucleus. And these are all apoptotic keratinocytes. Or the other term that people are going to use is dyskeratosis, or the other term is colloid bodies. So that is part and parcel of the lichenoid infiltrate. So now if we go back, hyperkeratosis on the top, wedge-shaped hypergranulosis, a very dense lichenoid infiltrate hugging the dermal epidermal junction in association with dyskeratosis or associated colloid bodies. And now because the keratinocytes are being destroyed, some of the keratinocytes are being destroyed, the pigment that is in the keratin. So in normal skin, melanophages are part and parcel of the epidermis. So for every 10 keratinocytes in the basal layer, there is a melanocyte. And these melanocytes, they produce the pigment, and this pigment is then sent to the keratinocytes. So the keratinocytes contain the pigment. So by some of these, when these keratinocytes get destroyed, the pigment will then get sent to the dermis. So you are going to see pigment incontinence in the dermis. So if you go a high power, you're going to see some scattered pigment throughout the infiltrate basically. So that is known as pigment incontinence. So that is all part and parcel of a lichenoid infiltrate, and understanding the pathophysiology will help that. Lymphocytes attacking the dermal epidermal junction, causing apoptosis, causing the pigment incontinence. So if you see all these combination of patterns, then it is a lichenoid dermatitis compatible with the clinical impression of lichen planus. And remember, lichen planus is supposed to not have any parakeratosis on the top, and it is not supposed to have any eosinophils in the infiltrate. So you have to always look at this at high power and then see if you see any eosinophils in the infiltrate. If you see eosinophils, then most likely it is a lichenoid drug eruption. It is not lichen planus. Another very important thing to remember is the clinical history. Is this a rash? So like if you see here, this is a rash. If it is a rash, then this is compatible with clinical impression of lichen planus or compatible with lichen planus, because many times the clinician will just say rash and then send you the biopsy. They will not say lichen planus. But if this is a single lesion, so remember, even a single lesion can look very similar. So here you can see this was a single lesion, came in as rule out basal cell carcinoma. And it has the same thing basically. Hyperkeratosis on the top, wedge-shaped hypergranulosis, dense lichenoid infiltrate and apoptosis. But because this is a single lesion, this is a lichen planus-like keratosis. So that is where your clinical history is very, very important. Is this a rash or is this a single lesion? And sometimes you will, if the clinician says rule out basal cell carcinoma, then you know that that is a single lesion because the clinician is looking at some single lesion and they're thinking of a neoplastic kind of lesion. And that is the reason they said rule out basal cell carcinoma. So if that is the case, then don't call it lichen planus, call it lichen planus-like keratosis. And here is another one which looks very, very similar. Again, same, very similar, where you have this hyperkeratosis, wedge shape. But if I go high power and I start looking very carefully, I see a couple of eosinophils here basically. As you can see, the eosinophils admix within the infiltrate. So if you see that, then this is a lichenoid dermatitis suggestive of a lichenoid drug eruption. So those are the three main differential diagnoses: lichen planus, benign lichenoid keratosis or lichen planus-like keratosis, both mean the same thing, and then lichenoid drug eruption. So that it should be very easy to differentiate the three if you understand the pathophysiology behind the three basically. And another very common thing that can come on your board exam in the lichenoid reaction pattern is this, where you see this lichenoid infiltrate, but that is limited to only one reteridge. So this is like it is limited to only one reteridge here basically. So you see this. This is the part of the epidermis. This is another part of the epidermis. And this pattern that you see here, the term that you'll read in the books is known as a ball and a claw pattern. So this is the ball of inflammation, and this is like a claw, like that. It is trying to like hold the ball. So these are the two claws of the pigeon or whatever you want to owl, whatever you think. These are the two claws, and it is trying to hold that ball. So the ball of inflammation and the claw. So it is known as a ball and claw pattern, and this is very classic for a condition called lichen nidus. So this can be on your board exam because you don't need any clinical history for this. If you see this ball of lichenoid inflammation that is limited to one or two reteridges, and then you see this claw-like pattern, then this is diagnosis is lichen nidus. Now this is the next reaction pattern, very classic again. Again, this is not going to be biopsied because you see this targetoid lesions here on the palms, and you see this mucosal inflammation here. So when a clinician sees that, they know this is going to be erythema multiforme. So you might get a biopsy that says rule out erythema multiforme. So what do we see in a biopsy of erythema multiforme? And this is an important diagnosis because you might even get this as a frozen section. So we'll talk about what can come in a frozen section. So what do we see in erythema multiforme? So again, starting from the top, you see this basket weave kind of hyperkeratosis or normal kind of hyperkeratosis. So this stratum corneum, this pattern is known as a basket weave. So you know that bamboo that is used to create a basket, and they will like intertwine with themselves, like the bamboo is intertwined to create that basket. So that very similar pattern is seen here in the stratum corneum. So this is known as basket weave hyperkeratosis. You see that here. And then within the epidermis, if you start looking at it carefully, you see this dyskeratosis throughout the epidermis. In the lichen planus, it was limited to the lower basal layers of the epidermis. Here you can see them at all levels of the epidermis. So if you go high power, you see this very pink cytoplasm and this pycnotic nucleus. And this is the term that is used for that is dyskeratosis. So remember, dyskeratosis at all levels of the epidermis, not only limited to the basal layer, but also in the superficial part of the epidermis. Here is another dyskeratosis. So you see a basket weave hyperkeratosis on the top. You see dyskeratosis at all levels of the epidermis. And then when you look at the dermal epidermal junction, you can see like this is like a moth-eaten appearance. What the term that you will read in books is a moth-eaten appearance, like an insect has come in here and like tried to chew up the dermal epidermal junction. So you see this vacuolar kind of changes at the dermal epidermal junction. You can see all these vacuolar kind of changes, and this pattern is known as a vacuolar interphase reaction pattern. Vacuolar means it is like creating these vacuoles. Interphase means it is in the interface of the epidermis and the dermis. And that is the reason it is called interphase. So it is a vacuolar interface dermatitis. You can see these vacuoles throughout the epidermis. And within these vacuoles, you might also see lymphocytes associated with it. And the term that you're going to see described in books is lymphocytic satellitosis. So these are all terms that you will read in books. You should understand the meaning of that. The satellitosis is this individual lymphocyte that you see in association with these vacuoles. So you see this vacuolar interface dermatitis, and then in the dermis, you see this superficial perivascular lymphocytic infiltrate. You might see some EOs, you might not see them. It is not needed to make the diagnosis. But if you see these features and the clinician wants to rule out erythema multiforme, then this is a vacuolar interface dermatitis compatible with the clinical impression of erythema multiforme. So basket weave hyperkeratosis, dyskeratosis at all levels of the epidermis, vacuolar interface changes at the dermal epidermal junction, and then the perivascular, superficial perivascular lymphocytic infiltrate plus or minus eosinophils. Erythema multiforme can be caused by multiple different things. It can be caused by viruses. It can be caused by drugs. It could be iatrogenic. So when it is caused by drug, you might see some of the eosinophils in the dermis. But if it is not related to a drug reaction, then you might not see the eosinophils. So don't waste your time trying to see the eosinophils. If you see this pattern, you can say compatible with erythema multiforme. But one thing that you have to remember here, again, the clinical history is very, very important. Because in exactly same reaction pattern, you're going to see in two other conditions. One is called a fixed drug eruption, and the other is called acute graft versus host disease. So if the patient has had some kind of a transplant and you get this kind of histology, then it is not erythema multiforme, it is a post-transplant reaction. So it is acute graft versus host disease. If the patient is developing this reaction every time when they take a drug, then it is a fixed drug eruption. But the histology is going to be exactly the same. You're going to see this vacuolar interface dermatitis, you're going to see dyskeratosis at all layers of the epidermis, and you're going to see the superficial perivascular infiltrate. So here is a case of, we'll come back to this one. This is a case of a fixed drug eruption, very similar, where you have the basket weave hyperkeratosis. You have the dyskeratosis within the epidermis. You can see this dyskeratosis. And then you have this superficial perivascular infiltrate. And then in the fixed drug eruption, if you look very carefully, you might see the eosinophils. And there is always this pigment incontinence because of the dyskeratosis. The next case is actually a graft versus host disease. Again, very similar reaction pattern where you have the hyperkeratosis, you have the dyskeratosis, and then you have the vacuolar interface changes. So all these are going to show you very similar histology. And like I said in my initial slides, your best friend is your dermatologist or your clinician. You have to talk to them. You have to have an open communication with them, because then only you can make a better diagnosis. Otherwise, you are always going to give them a wrong diagnosis. So always pick up the phone and then talk to them. And these slides have been shared with you. Like if you haven't looked at these slides after this talk, go back and look at these slides, and then try to think about what I said and look at these features, and then try to understand what we talked in the talk actually. Now coming back to the slide that I bypassed basically. So this is the slide that is always going to come as a frozen section. Now if you look at this one, what has happened is that the skin is completely peeled off. So the clinician has actually just taken a roll of the superficial peeled off skin and send it to you as a frozen section. And the case always comes in as rule out toxic epidermal necrolysis versus staphylococcal scalded skin syndrome. That is the only frozen section that you're going to get in dermatopathology. Rule out toxic epidermal necrolysis versus staphylococcal scalded skin syndrome. Now, staphylococcal scalded skin syndrome is a bacterial related infection. So, and the toxic epidermal necrolysis is usually associated with some drug or something else. So many times they will treat the toxic epidermal necrolysis with steroids. Now, if the main thing that they want to make sure this is not a bacterial infection, because they do not want to give steroids to a patient that has bacterial infection. Because if you give steroids to an infectious patient, the patient is going to deteriorate further basically. So your diagnosis is going to either help the patient or kill the patient. Because if they give the wrong treatment to the patient will die. So what is the underlying pathophysiology of a toxic epidermal necrolysis? So the term toxic, so it is related to some kind of a drug or something happening within the patient. Epidermal necrolysis. So the entire epidermis is necrolytic. So when you go and look at this here, you can see like the entire epidermis is becoming quite necrotic, or you will see this keratosis throughout the epidermis at a much higher level than you normally see in erythema multiforme. So if this was an acute, like initially it may look like erythema multiforme, but as the skin becomes quite necrotic, the whole skin starts to peel off basically. So if you get an entire necrotic layer of epidermis, then you're going to think about toxic epidermal necrolysis. So it will normally split at the level of the dermal epidermal junction. So because it splits at the level of the dermal epidermal junction, you see an entire layer of epidermis. In the staphylococcal scalded skin syndrome, let me see if I can pull out a slide of staphylococcal scalded. Compare public library. So in the staphylococcal scalded skin syndrome, the skin separates at the level of the stratum corneum. So you never, so they might take a roll of the stratum corneum and send it to you. So you are always going to see only the superficial part of the epidermis. You never see the entire epidermis. So if you get a roll of the only the stratum corneum or the superficial part of the skin, then you are going to think of staphylococcal scalded skin syndrome. If you get a roll of the entire epidermis that is necrotic, then you are going to think of toxic epidermal necrolysis. But that is the only frozen section that you're ever going to get in dermatopathology. So let's move on because you're already at 8:41. The other very common disease that can show some kind of a vacuolar interface change is this one, where you can see like if I go high power and I go and look at the skin from the tops, hyperkeratosis, pretty normal looking epidermis, no dyskeratosis here. But then if you look at the junction, you start seeing the vacuolar interface changes at the junction. So again, I'm dealing with a vacuolar interface dermatitis. But then if I zoom out, I also see an associated perifollicular and perivascular infiltrate. So a vacuolar interface dermatitis associated with a perifollicular or periadnexal and perivascular infiltrate in the dermis. You always have to think of connective tissue disease like lupus erythematosus and those conditions. So the classic thing that you're going to see in any kind of lupus patient is a vacuolar interface dermatitis at the dermal epidermal junction in association with the periadnexal or perifollicular. Here you can see like this is a follicle here and the inflammation is surrounding the follicle, and it is also perivascular. So you can see the inflammation is also around the vessels. And then if you like look at the skin very carefully, you can see there is a bluish tinge here. So if you do a Alcian blue or a colloidal iron, you will see increased mucin in the dermis. So all this combination of features can help you make the diagnosis of a connective tissue disease like lupus erythematosus. Moving on to the next pattern, this is a very classic case of bullous pemphigoid where you can see this large bullae in an older patient. So when you look at the biopsy, what you see in a case of a bullous reaction. So when you are talking about a bullous reaction pattern, like don't try to jump to a diagnosis that this is bullous pemphigoid. Always first see where the bulla is. So is the bulla within the epidermis or is the bulla within the below the epidermis, or which is termed as subepidermal. So the two terms that you will see whether the bulla is intraepidermal or whether the bulla is subepidermal. And based on that, your differential diagnosis will change completely. So here the bulla is below the epidermis, so it is subepidermal. So when you see a bulla that is subepidermal, the next question that should come to your mind is it associated with an inflammation? So yes, this one is associated with a lot of inflammation. And then the next question is, what is the kind of inflammation? So if I go and I see here, I see a ton of eosinophils here. So subepidermal bulla with inflammation that is composed predominantly of eosinophils, then your main differential diagnosis are going to be bullous pemphigoid. But again, remember, a bullous drug eruption can show you very similar features. A bullous arthropod bite will show you very similar features. So again, your clinician is going to be your best friend, because based on the histology, you cannot differentiate the three. You have to have the clinical input to like say whether this is a bullous arthropod bite, which would be most likely a single lesion, or is it a bullous drug eruption where the patient has been on a drug and the lesion suddenly appear after taking the drug, or is it bullous pemphigoid when you saw the clinical picture that I just showed you here basically. So that clinical input is going to be very important to like give them a very definitive diagnosis when you see a subepidermal bulla with a lot of eosinophils. Now, if you look at, I already showed you this case here. So here, where is the bulla? Again, first question, where is the bulla? This is an intraepidermal bulla. It's not subepidermal, it is within the epidermis. And if you look at where is it in the epidermis, it is subcorneal. So this is the stratum corneum. Remember, we talked the superficial layer is the stratum corneum. So where is this within the epidermis? It is subcorneal. So if I see a subcorneal bulla, then my differential diagnosis is going to be either, we talked about one is the staphylococcal scalded skin syndrome, where you might just get a layer of the stratum corneum rolled up as a frozen section. So if you see only the stratum corneum, then you're going to think of staphylococcal scalded skin syndrome. And the other conditions that can cause very similar stuff is pemphigus foliaceus and then bullous impetigo. So again, remember like that pattern recognition is very, very important. And then your list of differential diagnosis will narrow down quite a bit. So your intraepidermal subbulla, that is subcorneal, and then your differential diagnosis, only three of them. Either it is staphylococcal scalded skin syndrome, it is bullous impetigo, or I'm dealing with pemphigus foliaceus. And again, those can be differentiated based on the clinical input. If I see the same reaction pattern that we saw in the previous one, intraepidermal, subcorneal, and then associated with a lot of neutrophils here. You can see there's a lot of neutrophils here within the bulla, then it is bullous impetigo. If it is a very clean, there is not too much of inflammation, very, very clean here, then it is staphylococcal scalded skin syndrome. And then the other one is pemphigus foliaceus, where you can see that there is some kind of a perivascular infiltrate. But again, the clinical input is very important. This is mostly middle-aged to older patients, and they have this very typical looking skin lesions that look like pemphigus foliaceus. And then obviously the immunofluorescence is going to be a big help, because the IgG and C3 pattern that you see in the epidermis on immunofluorescence can only be seen in pemphigus foliaceus, and it is not going to be seen in either bullous impetigo or staphylococcal scalded skin syndrome. So here again, the bulla is intraepidermal subcorneal, where you can see the stratum corneum is sloughed off, but then the immunofluorescence pattern will help make the diagnosis. Now again, this is another very classic case that definitely can be on exams also. So let's look at this very carefully. So again, this is a bullous reaction pattern where the epidermis has mostly sloughed off. You can see like the part of the epidermis is gone. So it is a intraepidermal bulla. So that is the first thing that we have decided, that this is a bulla which is intraepidermal. Now this is, the previous one was below the stratum corneum, but where is this one? This is above the basal layer. So if I look at this very carefully, you can see that this is the basal layer of the epidermis that is still there. And then the rest of the epidermis is sloughed off basically. So this is intraepidermal suprabasal. So let's go back to the skin here. If you look at this one here, sorry. So this is the epidermis, this is the stratum corneum, and then this is the basal layer here. So this is intraepidermal subcorneal, because this is the stratum corneum. And if the bulla is just above this basal layer, then it is called suprabasal. So the one that I was showing you is now intraepidermal, but now suprabasal. And this is very, very classic for pemphigus vulgaris. So if I see this, I know my diagnosis is going to be pemphigus vulgaris, where I see this intraepidermal suprabasilar bulla. And this was previously in 1950s and 60s, this was called a row of tombstones, because most of the patients that developed pemphigus vulgaris, they died. There was no treatment available at that time. So when a pathologist saw this, it was actually termed as a row of tombstones, because that is like what you see in a cemetery. You see a row of tombstones in a cemetery. So that is what they always equated that with pemphigus vulgaris. But now there is treatment available. Most of these patients will survive. So they don't, that same terminology doesn't help, doesn't stick. But it is a good way to look at these cases because you can see like this basal layer is almost like a row of tombstone that is stuck to the dermis. The rest of the epidermis is sloughed off basically. So that is and if you do the immunofluorescence, again, you're going to see the IgG and the C3 fishnet pattern within the epidermis. Let's keep moving. Now this is the next one where again, where is the bulla? It is subepidermal. So now this is the epidermis is there and now this is subepidermal. Now, is this associated with inflammation? Not like you saw quite a bit of inflammation in the bullous pemphigoid. Here, there is not too much of inflammation. So now this is a subepidermal bulla, which is cell poor. That is how you, in the books, they call this cell poor. By cell poor means there is not too much of inflammation. So if you see this, then your most likely diagnosis is going to be porphyria. And when you read about porphyria in the skin, they are going to talk about two more things. One is they are going to talk about festooning. So what does the term festooning mean basically? So you see this dermal papillae here, it does not collapse. It still maintains that outline. And the underlying pathophysiology in porphyria in the skin is that the dermis becomes very, very sclerotic. By sclerotic, what do you mean? It becomes very hard. And because the skin becomes very hard and sclerotic, this dermal papillae doesn't collapse and it maintains this kind of an outline. And that the term that you will read in the books is known as festooning. And the other term that you're going to read is caterpillar bodies. So what is caterpillar body is this base, like if you look at the normal skin, the dermis at the this is the epidermis and this is the dermis, and between the epidermis and the dermis there is a basement membrane layer. So when this split happens, this basement membrane layer gets stuck to the roof of the blister or roof of the bulla. And the stuck on basement membrane material at the roof of the bulla is what is termed as caterpillar bodies. So the two terms that you're going to read in when you read about porphyria in the skin is one is this festooning and the other is this preserved basement membrane at the roof of the bulla, which is termed as caterpillar bodies. So if you see this subepidermal cell poor bulla that shows this festooning and shows this caterpillar bodies, then you're dealing with porphyria. And these are all very classic cases and definitely they can also be on a board exam. So that is the reason I'm showing you these cases. But again, these are very classic cases when you're practicing, you might not see all these very, very classic cases because the patient is being treated and then you get a biopsy of the skin. And then again, now this is the last one, I think, for the bulla. So again, where is the bulla happening here? Like you can see like the epidermis is completely sloughed off from here. So this epidermis is completely sloughed off from here. So it is a subepidermal bulla. Is it associated with inflammation? Yes. What is the kind of inflammation? So if I go high power, I can see that this is predominantly a neutrophilic infiltrate. So you can see all these multi-lobes here. So this is a neutrophilic infiltrate. So in the bullous pemphigoid, you saw a lot of eosinophils. In the PCT, you didn't see any kind of inflammation or porphyria. And in this one, you see a subepidermal bulla with a ton of neutrophils. So what is your diagnosis? This one is very classic for linear IgA vesiculobullous disorder. So subepidermal bulla with a ton of neutrophils, most likely diagnosis is going to be linear IgA vesiculobullous disorder. And if you do the immunofluorescence, you're going to see what the term says, linear IgA. So I'll see a linear IgA at the dermal epidermal junction. And the other differential diagnosis is bullous lupus. So those are the two diseases, bullous lupus, which is very uncommon. And the more common one is the linear IgA vesiculobullous disorder, which is going to show you a subepidermal bulla with a ton of neutrophils associated in the dermis. Moving on to the next one. So let's make this straight here. So now again, when we start looking at this biopsy, there is a kind of a excoriation here, the patient is scratching. The rest of the epidermis looks pretty normal. If you look at the dermal epidermal junction, there's nothing much here. But then the main action is in the dermis. So what do we see in the dermis is a superficial and mid-dermal perivascular infiltrate. Some even going in the dermis. So now if you go high power and look at this infiltrate, so you're most likely dealing with a perivascular dermatitis because it's mostly a perivascular inflammation in the dermis. So now if you go high power and you start looking at this infiltrate, it is composed of a lot of lymphocytes. But then if I start looking around, do I see? So the first, you can also start seeing this orange granules within some of these cells, and these are eosinophils. So you can see that there is an eosinophil here basically. So if I look around very carefully, there's another eosinophil here. There's another eosinophil here. There's another eosinophil here. So what I see is a perivascular, which is superficial and mid-dermal or deep lymphocytic infiltrate with admixed eosinophils. So if you see that, then you're most likely dealing with a drug eruption. So a superficial and mid-dermal perivascular dermatitis with admixed eosinophils, most likely it's a drug eruption. But again, clinical history, very, very important, because if this was a single lesion, then this is going to be a arthropod bite. So here is an example of an arthropod bite that shows a very similar reaction pattern where you have nothing much in the epidermis. But if you look at the dermis, you have the superficial and mid-dermal perivascular lymphocytic infiltrate associated with a lot of eosinophils. You can see all these eosinophils here, the orange granules. So very, very similar, but because the clinical history was this is a single lesion, it is not a rash, this is an arthropod bite reaction. If this was a rash, then this is most likely a drug eruption. So again, remember, clinical pathological correlation is very, very critical in inflammatory dermatopathology. And a very similar reaction pattern can sometimes be seen if this was an older patient. The one diagnosis that you should always keep as the zebra in your mind, where you see this perivascular infiltrate with, you can see again, this is perivascular inflammation. And then there is admixed eosinophils. But one very different thing here is that you see all these eosinophils also going within the epidermis. You see all these eosinophils going into the epidermis. So it is eosinophilic exocytosis. We talked about exocytosis in spongiosis, where you see the lymphocytes going into the epidermis. So that was lymphocytic exocytosis. This is eosinophilic exocytosis. So if you see that, the one thing that you should always keep in your mind is this could be the early phase of bullous pemphigoid. So superficial and mid-dermal perivascular infiltrate with eosinophils, the three main diagnoses to consider: drug eruption, arthropod bite, and an early phase of bullous pemphigoid. Those are the three common things that we see in skin. So keep that in your mind, and then based on the clinical input, you can then make your diagnosis. And if this was on the board exam and you saw this eosinophilic exocytosis, then pick bullous pemphigoid, or because that is a very classic thing that you see in the early phases of bullous pemphigoid, where you see this eosinophilic exocytosis. But again, remember, in real life, it can also happen in a drug eruption. It can also happen in an arthropod bite reaction. So just based on this, you cannot give a definitive diagnosis. You need more clinical input to give the definitive diagnosis. But on the board exam, pick bullous pemphigoid. So we are already running out of time. So maybe I'll do this last case and then we can stop for any questions. Like what do you want me to do, Mohammed?
If you want, you can continue.
Okay, if it is okay with the... Okay, we'll finish it off then, okay. So now this is another very classic case that you are definitely going to see in your practice. So let's go a little bit back, low power. And all these slides are shared with you. So please go back and look at them, because then only you will try to and try to think what I said. So then you start getting a better sense of all the things that we talked about. So again, looking at the stratum corneum, pretty normal. Looking at the epidermis, pretty normal. Looking at the dermal epidermal junction, pretty normal. But the action is happening in the dermis. So what is happening in the dermis? We see a lot of inflammation in the dermis. So if we go high power, what is the inflammation that we see here? So we see a ton of neutrophils here. So you can see all this is neutrophils here. So whenever you see neutrophils in the dermis, the first thing to ask yourself is, do I see any vasculitis? Now that is a very important term to understand in skin. What does vasculitis mean? So when you talk about gastritis, we talk about neutrophils within the gastric mucosa. When you talk about tonsillitis, we talk about neutrophils within, but here just presence of neutrophils doesn't equate to vasculitis. So here if you see just neutrophils around the vessels, that doesn't equate to vasculitis. The most important thing that you want to see before you can say that this is vasculitis is fibrinoid degeneration around the vessel wall. So this is the endothelial cells, which is, so this is a vessel, and around the vessel wall you see this pink hyaline material around the vessel. And the term that you will see in the books is called fibrinoid degeneration. So this is a very important thing to look for if you want to call anything vasculitis in the skin. Just the presence of neutrophils around the vessels will not equate to vasculitis. You want to see the fibrinoid degeneration in association with the neutrophils. Then you can say that this is vasculitis. And vasculitis is an important diagnosis that you can make because it can sometimes be very lethal to the patient. So it is a very important differentiation to make, that does my patient have vasculitis or not, basically. And just the presence of neutrophils do not equate to vasculitis. You want to see this very pink hyaline material around the vessel wall in association with the neutrophils that are traversing the vessel wall. So if you see that, then you can say this is vasculitis. Now the other feature that I see here is this blue dots that you see scattered throughout the vessels. So what are these blue dots? You can see these blue dots here. So these are actually the neutrophils of the leukocytes, or the neutrophils that are broken up. So what if you see what is the term that is used for a broken up nucleus is clasia, CLASIA. So clasia means breaking up of the nuclei, and leukocyte is a neutrophil. So leukocytoclastic, that is how this vasculitis is called. Leuko, which is the neutrophil. Leukocytoclastic, clastic means breaking up of the neutrophilic nuclei, and then the vasculitis. So leukocytoclastic vasculitis, LCV, that is the term that is used for this kind of diagnosis, for this kind of pattern, where you see the vasculitis in association with the neutrophils, and also this blue dots scattered throughout the dermis, which is the broken up nuclei, the clasia of the leukocyte. So leukocytoclastic vasculitis is the term that is used for this diagnosis. And again, like spongiosis, leukocytoclastic vasculitis can be caused by many different things. So you do not have to try to find the root cause. All you're going to say is this is compatible with leukocytoclastic vasculitis, and then leave it to the clinician to decide whether this is associated with a drug, whether this is associated with connective tissue disease, whether this is associated with some kind of an iatrogenic cause. That the clinician will decide, but it is important for you to give them that this is some kind of a vasculitis, because then they will definitely treat the patient in a very acute manner. But again, the fibrinoid degeneration is very important before you just call it vasculitis, because just presence of neutrophils doesn't equate to vasculitis. And the one condition that I didn't have a slide here, but because we have time, I'm just going to pull that slide up. So here is a slide that is another that can be on your board exam, or if you're like prepare. Like what you see here is again normal looking epidermis, but the dermis you see a lot of inflammation, and if you go high power, you can see like this inflammation is composed of a lot of neutrophils here basically. So like I said, when you see a lot of neutrophils, the first thing is to go around and look at the vessels. Do I see any vasculitis here basically? So here you can see that these vessels are pretty clean here basically. Like here is a vessel here. I don't see that fibrinoid degeneration. So this does not equate to vasculitis. What this is just a neutrophilic dermatosis, and the classic case that you would see here is sweet syndrome. So sweet syndrome is a neutrophilic dermatosis, but no vasculitis. There's a lot of neutrophils, but no vasculitis. Comparing that to this one where you see the neutrophils, but then there is the fibrinoid degeneration around the vessel wall. So this is actually vasculitis. Now coming to this other next case where you see this very round looking lesion on the skin. And the term that you're going to see in books, this is termed as an annular lesion. So this is like the clinician is going to say annular lesions, rule out this and that basically. So the term that is used clinically for this is annular. So this is an annular lesion. And when you look at the biopsy here, so we actually see another annular lesion here basically. So what do you mean by annular? Like I said, round or, so this is like a round lesion that you see here basically. And what is this round lesion composed of? So if you look at this round, it is composed of this round is composed of lymphocytes. And then there are associated macrophages. The large cells are the macrophages, and then there is lymphocytes. So this is almost like a palisade. A palisade is a fence around the house, or sometimes the palisade is also termed for a necklace. So necklace or a fence around the house is what is termed as a palisade. And in the skin, like if you see macrophages, many times it is termed as a granulomatous dermatitis. Like remember, in other parts of the skin, we talk about giant cells as being part of a granulomatous reaction. In the skin, whenever you see a lot of macrophages, people will tend to call that a granulomatous dermatitis. Now, this is forming like a palisade or a fence or a round lesion. And that is the reason this is known as a palisaded granulomatous dermatitis. So this palisade is composed of lymphocytes and macrophages. And then when you go a little bit high power, it is enclosing this degenerated collagen. So you can see this is pink structure is the collagen bundle. And it is not completely like dead. You can see that the shape of the collagen bundle is a little bit distorted. And how do you know that? Because if I go here and I look at the normal skin here, you can see like this collagen bundle doesn't have that very pinkish look that I see here basically. But if I go within the palisade here, you can see like this collagen bundles have started to like degenerate a little bit. And because it is not completely dead, but it has started degenerating, the term that you're going to see in the book is necrobiosis. So it is not completely necrotic. It is not completely normal. So something that is between normal and necrosis is necrobiosis. No, it's not. Necrosis is completely dead. And then on the other extreme is the normal collagen bundle. So something in between is termed as necrobiosis. So within this palisade of that is composed of macrophages and lymphocytes, you see necrobiotic collagen bundles. And then you can also see that there is a bluish tinge here basically. So that is increased mucin. So now if you go low power, there is a palisaded granuloma that is enclosing necrobiotic collagen bundles and increased mucin. So if you see this, your diagnosis is going to be granuloma annulare. Very, very classic, again, can be on your board exams. So granuloma annulare, and the clinical picture is always like this, where you see this annular lesion also on the skin. Again, the clinical picture is going to be very important because similar pattern can sometimes be seen in other conditions. So other condition that can show you something of a similar pattern is this one where it's not very similar, but again, it has this kind of a palisaded granuloma. But then the other classic thing that you see here, let's look at this. So what on low power, like the term that is sometimes described for this pattern that you see here is cake layers. So when you see a cake, it is composed of multiple layers. So here you can see that this is also has some kind of layering here. So you have a layer of inflammation. Then you have this layer of very pink or sclerotic collagen. You have a layer of inflammation, sclerotic collagen. Then you have layer of inflammation and sclerotic collagen. So it is like a layering, cake layering. That is the term that is used. So if you go high power and you look at these layers, this is very pink looking collagen sclera here. And then the inflammation, that layer is composed of lymphocytes. And you might see some plasma cells, you might see some giant cells, you might see some macrophages. So the layer is composed of chronic inflammation, so lymphocytes, plasma cells, macrophages, sometimes even eosinophils, but it is a layer. And so when you see this layering of sclerosis and inflammation, that is granulomatous, then this is very classic for necrobiosis lipoidica, which is associated with diabetes. So you must have heard NLD, necrobiosis lipoidica diabeticorum. But there are some cases that are not always associated with diabetes. So that is the reason we now just call it necrobiosis lipoidica, because it can be associated with other conditions. When it is associated with diabetes, you call it NLD. When it is not, then you call it NL basically. But the classic pattern that you see here is this cake layering that you see here basically. So layers of the skin that is sclerotic inflammation is very classic for NLD. And another very classic thing that you're going to, this is another that shows a very similar reaction pattern where you again see like this is forming like a palisade. You can see this palisade here basically. So if I go eye power, this palisade is now again composed of lymphocytes and macrophages. You can see that it is composed of these lymphocytes and macrophages. But now when we talked about the necrobiotic collagen within the palisade. So now if I go within the palisade here, this is not necrobiotic collagen, but I see a very pinkish collagen bundle. So if I see this very pinkish kind of collagen surrounded by this palisade of macrophages, this is very, very classic for a term known as rheumatoid nodule. So again, a palisaded granulomatous dermatitis in association with this very pinkish fibrinoid kind of change of the collagen bundles. Remember, we talked about the fibrinoid degeneration around the vessel that was associated with leukocytoclastic vasculitis. This is fibrinoid degeneration of the collagen that is within the palisade of the macrophages and the lymphocytes. And that is very, very classic for rheumatoid nodule. So in the palisaded granulomatous dermatitis, there are a couple of conditions that you always should think about. One was the granuloma annulare, where you saw the necrobiotic collagen and increased mucin. One is this rheumatoid nodule, where you see this very fibrinoid degenerated collagen surrounded by the palisade. And then I think this is the last pattern where you see this erythematous pinkish lesions that are on bilaterally on the both of the shin of the patient. And then this very classic inflammation that you see within the subcutis now. So now if you look again here at this inflammation here, epidermis looks pretty normal. The dermis has a little bit of a mild perivascular lymphocytic infiltrate, but the main action is happening in the subcutis now. So what is happening in the subcutis? I start seeing a lot of inflammation here. Now, if you look at the fat is composed of this fat lobules, and between the fat lobules is the septa. So those are the two things that you see in the subcutaneous fat. One is the lobules, and between the lobules is the septa. In normal skin, the septa are very thin like this basically. You can see like the very, very thin septa that separate the lobules. But in this condition, what is happening is this septa become quite widened and fibrotic. So you can see that this is a widened and fibrotic septa here. And then within the septa, I see a lot of inflammation here. So you can see lymphocytes, you can see giant cells, you can see plasma cells, sometimes even eosinophils, but it is acute and chronic inflammation within the septa that is thickened and fibrotic. And some of this inflammation might start going into the lobules, but mostly the lobules look pretty normal. So in this, when you start seeing inflammation in the fat, you have to think about, where do I see the inflammation? Is it limited to the septa, or is it associated with the lobules? So if it is a lobular panniculitis, you have to think of different diagnosis. If it is a septal panniculitis, like this is known as a septal panniculitis because this is the fat and there is inflammation associated with the fat. So it is a panniculitis. So septal panniculitis, and this is very classic that you see here, is thickened septa associated with chronic inflammation. So the diagnosis is going to be erythema nodosum. Classically, it is associated with patients taking OC pills, and these are younger patients that can present with this bilateral lesions on the shin or on the lower leg, mostly in the front of the lower leg. It can be associated with other disease, like sometimes with other drugs, sometimes with connective tissue disease, sometimes with sarcoidosis, and they all present with this septal panniculitis, where you have this thickened and fibrotic septa associated with chronic inflammation, and the lobules look pretty clean basically. But then there could be also a lot of lobular panniculitis. So just to show you, like this is a case of where the inflammation is mostly in the lobules of the fat basically. So this is the fat lobule, and then you see this a lot of inflammation within the lobule. So this is more of a lobular panniculitis. So lobular panniculitis is a whole lecture in itself. We will not go into the details, but I just wanted to give you an overview that when you see inflammation in the fat, think first, where is the inflammation? Is it related to the septa or is it related to the lobules? And then based on that, your differential diagnosis will be different basically. So that is the last slide, and this should give you a very good overview of how to start thinking of when you look at a skin biopsy basically. So we can take any questions right now, basically. You are mute. Your voice is not coming
Okay.
up.
So we have a question in a chat box that if we see neutrophils around the vessels without the fibrinite necrosis or degeneration, can we still call it like early vasculitis?
Like most likely you should not be calling it early vasculitis. There is some conditions like when you see an urticarial vasculitis, which is one of the conditions that you're going to see in the skin. People tend to like let go if they don't see the neutrophil, like they do not see the fibrinal degeneration. But as a if you are going to follow like a textbook rules, then you definitely want to see the fibrinal degeneration on the vessel wall to call it vasculitis. You always have to be a little bit wary about the clinical picture. But yes, for the textbook definition for vasculitis in the skin is dependent on the fibrinoid degeneration, not on the presence of the neutrophil. You have to have the neutrophils, obviously, but without the fibrinoid degeneration, a textbook doesn't call it leukocytosis. Like it is not equivalent to vasculitis.
Okay. So the next question is if the clinical query is necrotizing fasciitis, so what will be the major histological findings?
Yeah, necrotizing fasciitis, as the term is talking about, it is the inflammation is mostly related to the fascia, which is below the subcutis. So necrotizing again, because there is going to be necrosis. So what you're going to see a lot of necrosis in the lower part of the subcutaneous fat and below the fat. And sometimes you might see eosinophils, sometimes you might not see eosinophils, but they are not needed for the diagnosis basically. But the inflammation and the necrosis is mostly related to the lower part of the subcutis and the fascia, and that is the necrotizing fasciitis.
Mhm. Okay. And
In bullous lesions, should we always do immunofluorescence staining? It's part and parcel of the diagnosis because many of them can have very similar reaction patterns. Like I said, a bullous pemphigoid could look like a bullous arthropod bite, could be like a bullous drug, or the linear IgA could look like lupus, like a bullous lupus. So definitely the immunofluorescence is needed for a definitive diagnosis. Vacuolar degeneration can be seen in spongiotic pattern very rarely, basically, very rarely. Like you never say never because it can always happen in pathology, but spongiotic pattern doesn't usually have a vacuolar degeneration at the dermal epidermal junction. Can you please repeat how to diagnose pre-bullous BP actually? Okay. So in the pre-bullous BP, like I said, you're going to see the superficial and mid-dermal perivascular infiltrate with eosinophils. But the other classic feature that I've always seen is this eosinophilic exocytosis. So you start seeing eosinophils also within the epidermis and sometimes even lining up the dermal epidermal junction. If you start seeing those in the epidermis, then you definitely have to think that most likely I'm dealing with the urticarial or the prodromal phase of bullous pemphigoid.
I think there are no more
Few
questions.
words about Haley disease and diarrhea and Grover's, please. Okay, we can talk about that. Uh, if we talk about Haley disease, like rather than talking about it, let's do this basically. So let's go here. Uh, so I'm going to go to the slide library and then type in Haley. So a Haley disease, what you see is an intraepidermal split. So like what you normally see in a Haley disease is part of an intraepidermal split. So like let's look here. So this is a case of Haley disease where you see this intraepidermal split here. But most of the cases, like it is an end-to-end split basically. So you can see that the split is starting from one layer of one end of the skin, and it goes to the other end of the skin. And if you go high power and you can see that the intraepidermal split is at the level of the spinous layer of the skin. So we talked about the granular, so we talked about the stratum corneum on the top. Then we talked about the granular layer below that. Then we talked about the basal layer. And the middle layer of the skin is known as the spinous layer. And the reason it is known as a spinous layer is because these keratinocytes, they tend to like form like this, almost like a rectangular spine. So in the heli, the layer, the split normally tends to occur in the middle of the epidermis. So this is the spinous layer. Sometimes you can also see the split occurring suprabasally in heli. So you have to always remember, when you see something that looks like pemphigus vulgaris, the other differential diagnosis is always going to be heli. A couple of things, like heli will never involve a follicle. Pemphigus vulgaris tends to involve a follicle. And then if you do the immunofluorescence, you are going to see the intercellular IgG and C3 within pemphigus vulgaris, and you will see a negative immunofluorescence in heli. So again, there was another question, immunofluorescence. It is important because many times you have to differentiate these conditions. So if you see a split in the epidermis that is like throughout the epidermis, in the middle layer of the epidermis, sometimes suprabasilar, and you see this floating keratinocyte. So what has happened is this keratinocytes have completely broken apart. And the term that you're going to read about is acantholysis. So there are two terms that we talked about: acanthosis, which is thickening of the epidermis, and the acantholysis is when these keratinocytes completely break off and you start seeing them floating within the bulla. So that is acantholysis. So intraspinous bulla associated with acantholysis. And sometimes the other term that you're going to read in heli is a dilapidated brick wall. So a dilapidated means a two-layer brick wall. So this is like one layer on the top and another layer at the bottom. And these look like bricks basically. So that is the term. This is a dilapidated brick wall. So intraepidermal split, that is like from one end to the other. If there was a follicle, it does not involve the follicle, and it has this acantholysis. And if you do the immunofluorescence negative, and those are, then you can call it heli disease. And the Grovers and Darius can look very similar. Where, let's open up a Grovers. This is not a good case. Let's find a better case basically for Grovers. So I want to show you something that is very classic so that you remember the stuff basically. Yeah, this one is good. Okay. So what is the like the way to remember Grovers is like, what is the other term that people use for Grovers is focal acantholytic dyskeratosis. So the other term that is sometimes used for Grovers is focal acantholytic dyskeratosis. Now remember all these terms. So focal is like in heli, what did we say, that the entire epidermis is involved. So now this one is very focal. It's not the entire epidermis. Then acantholytic. So you start seeing this. Remember we talked about acantholysis being the individual keratinocytes that are scattered throughout the lesion. So focal acantholytic dyskeratosis. Remember what we talked about dyskeratosis? You start seeing this pinkish keratinocytes that lose the nucleus basically. So if you see these three terms, then you are most likely dealing with Grover's disease. The Darius can also look very similar, but the Darius tends to have a lot of hyperkeratosis on the top basically. But again, they can look very, very similar. The clinical input is very, very important, like whether the patient has the clinical symptoms of Darius or whether it is Grover's, but they can look very, very similar basically. But focal acantholytic dyskeratosis is the term that people also use for Grover's. And if you keep that in mind, then you will see all the features. It is focal, there is acantholysis, and there is dyskeratosis.
Okay, and there is a question like how do we differentiate between the vesicle formation and spongiotic reaction from the vesicular-bullous lesions?
Okay. So vesicular formation, like how do you differentiate intraepidermal vesicular from vesicle formation in acute spongy? Yeah, definitely. So when you talk about, let's go back here. And if we go to this slide here, which was this one, no, this one. So remember when we talked about spongiosis, what does spongiosis mean basically? Again, like always go back to the pathophysiology. What does spongiosis mean? Spongiosis means it is eczema of the epidermis. And what does eczema mean? Collection of fluid. Like if you look at eczema in other, like if you look at if you edema, sorry, edema of the skin. So what does edema mean? Edema means collection of fluid. So the collection of fluid, what does it do basically? The collection of fluid causes the separation of the keratinocytes. So the keratinocytes, they have this, you can see when you look at these keratinocytes, they start seeing increased spaces between the keratinocytes. So they start a little bit separating out basically. So when this becomes extreme, then you start seeing this big space that is filled with fluids, and that is what is termed as vesiculation. Now, how do you differentiate this from a bullous lesion? So a bulla is never going to be associated, is because if you look at the pathophysiology, what is happening here, it is edema of the skin. So to get to this, you still have to have the separation of the keratinocytes showing on the side basically. So if you don't see this associated edema of this epidermis, then it is most likely not vesiculation, because to get to this point, you also have to see the separation of the keratinocytes separating out in the side. So here you can see there's a lot of spaces between the keratinocytes. So if it was a bulla, if you look at outside of the bulla, you are not going to see the separation of the keratinocytes. If it is vesiculation, because that is part of the whole pathophysiology, you're going to see the separation of the keratinocytes associated with it. And that could be an easier way to differentiate between vesiculation and something that is causing an intraepidermal bulla. Always go back to what is causing it, what is the physiology of the whole thing. That will help you understand the histology in a much better way, basically.
So I think there are no more questions for now. And thank you very much, Dr. Raj. It was a very comprehensive review of the inflammatory dermatopathology. And it was something like nostalgic for me, because when I was a medical student, I rotated with you at Mount Sinai. And so I kind of remembered that thing too. So thank you very
Thank you
much.
very much for hopefully. And if you have any questions, my email, I'm a dermatopathologist, so the email is easy to remember, skinpathology@gmail.com. So very easy to remember. You can always send an email and see if you have any questions.
Yeah.